So if you can see the slide, it's full of Bs. And I hope you don't forget that B cell lymphoma is the most common type of orbital lymphoma. And I hope this slide will help you remember that. So as a treatment team, when dealing with orbital lymphoma, it is usually composed of us, the ophthalmologist, the medical oncologist, and the radiation oncologist. Usually, that's the core. That's the core team when treating with orbital lymphoma. At times, it is our specialty that sees lymphoma first, especially if it's a primary orbital lymphoma, meaning there was no lymphoma in the past. There's no other lymphoma in the eye, and it's not an extension of a lymphoma near the eye. Okay. So what are the treatment options that we can do? First is surgical treatment, just like what Dr. Winky Imperial beautifully discussed. Usually it's to debulk the tumor. Usually if it's a circumscribed tumor, you can completely excise it. If not, you debulk it and you can decrease the tumor load. It's also important, surgery is to determine what kind of lymphoma it is. And when you determine what kind of lymphoma it is to determine which subtype of that lymphoma you're dealing with. Usually, surgery is not done alone, but in combination with chemotherapy and radiotherapy. Looking at this scan, at the right eye is a trademark of lymphoma, which is the molding. And this is the surgical photo of that scan, and it was beautifully excised. The mass was beautifully excised. There is a saying in treating cancer that if you have no meat, you cannot treat it. And that is a mantra of most of the medical oncologists and radiation oncologists. So it's important to biopsy these masses, especially if we are not sure what we are dealing with. Just like the topic or the title of our lecture series tonight, you never know what you're going to get. Okay, so another type of treatment is radiation. Radiation is usually reserved for the low-grade type of lymphomas when it is used alone or by itself or as monotherapy. It offers very good local control rates. And what we need to check in our patients who have undergone radiation is the side effects that we know of, especially in dryness, cataract, radiation retinopathy, NVG, neovascularizations. It's not only sufficient to check the eye that has the pathology, but to look at the other eye also because it can have the side effects of radiation. Okay, so this is a scan of lymphoma. It is a biopsy case of lymphoma. There's bilateral molding on the eye, both laterally, and after radiation with a radiation oncologist, you can see, I'll turn it back again and forward, back again and forward. The mass has beautifully regressed. So aside from surgery and radiation, chemotherapy is also given to lymphoma. And in contrast to radiation, chemotherapy is given to the high-grade lymphomas. We will discuss these later. Usually high-grade is diffuse large B-cell lymphoma or mantle cell lymphoma. So the new drug or relatively new drug that is used now for chemotherapy of lymphoma is rituximab, and it is given with other chemotherapeutic drugs in the CHOP acronym. C, cyclophosphamide. H is hydroxydoxorubicin. So doxorubicin is what we are used to. O is the brand name of vincristine, and P is prednisone. So it is very important to note that if you are treating any orbital pathology with prednisone and it is responding well to steroids, you cannot totally rule out a malignancy because lymphomas can respond to steroids also because of the P in our CHOP, which is prednisone. So in cases of doubt, like a box of chocolates, let's ask Dr. Imperial and refer to his lecture. maybe we need to do a biopsy and a surgical management for the patient. So I just was browsing the net yesterday and I bumped into this website from Roche. As a non-pathologist, I was amused by this, and looking at slides is not one of my forte. But when I looked at these, comparing follicular lymphoma and diffuse large B-cell lymphoma, medyo nagkaroon ako ng idea what it looks like. No? So for follicular on the left and diffuse large B-cell on the right, these are I guess, the differences. Let's ask Dr. Valera if these are right. For diffuse large B-cell, since its name is diffuse, the cells are also diffuse. In contrast to follicular, they are clumped together. And as I discussed a while ago, there are high-grade lymphomas and low-grade lymphomas. Yung follicular is one of the low-grade lymphomas, turtle, mabagal, kumalat. And the diffuse large B-cell lymphoma is one of the high-grade lymphomas, like a cheetah, mabilis siya kumalat. So here are just some numbers from the slide. EMZL, that's the most common type of B-cell lymphoma in the orbit. Fortunately, it's the most common, and it's also a low-grade turtle. Mabagal siya kumalat. And for low grades, early stage, they use EBRT or radiation. So for extranodal marginal zone, or sometimes it's called MALT, it is used, radiation is used as monotherapy. But for late stage, as I said earlier, late stage, kapag may systemic manifestation na, and that's where the medical oncologist comes in, sabihin sa'yo, Doc, meron ng parang metastasis, we need to do chemo. And that's when we use chemo for these low-grade tumors kapag may kalat na. Okay? So for extranodal marginal zone, which is one of the lower grade types of lymphomas, matagal yung relapse niya. 3 years bago mag-relapse, if it even relapses. And the disease-specific survival, meaning yung death nga from the lymphoma, yung na-study nila. For MALT lymphoma, the disease-specific survival at 5, 10, and 20 years, very high. 96, 92 at 5 and 10, and at 20 years, 84% survive. So ang early stage EBRT versus early stage chemo plus EBRT, they are comparable in survival at 10 years for EMZL lymphoma. Moving on to the high-grade tumor, high-grade lymphoma, which is diffuse large B-cell lymphoma, of 779 patients, 15% were diagnosed with this. At early stage pa lang, it is a combination now with EBRT and chemo, with or without rituximab. But at late stages, it is better to give rituximab for these types of lymphoma. Disease-specific survival at 5 and 10 years, way lower compared to the MALT lymphoma. From 96, 54 na lang dito at 5. From 92 at 10 years of MALT lymphoma, 41 na lang dito at diffuse large B-cell. So this is a very aggressive type of B-cell lymphoma. And when nag-relapse yung patients with B-cell lymphoma, obviously, when you come to think of it, it's obvious that they have a poor prognosis for patients that do not relapse. And at late stage versus early stage of this kind of lymphoma, 25% versus 51% at 10 years. So kapag 25% na or late stage na yung patient mo, the prognosis is not really that good. Okay, so for follicular type of lymphoma, this is one of the lower grades na naman. So just like the MALT kanina, early stage is an EBRT monotherapy. Late stage, it's a combination of chemo and EBRT. And for follicular types of lymphomas, mas ang tagal nung medial duration ng relapse for follicular lymphoma patients, 92 months. I don't want to do the math sa years, 92 months na lang tayo. And disease-specific survival at 5 and 10 years, also very high. Lower than MALT lymphoma, but definitely higher than diffuse large B-cell lymphoma. So in follicular lymphoma, B-cell lymphoma, there's no significant difference in the 10-year disease-specific survival between the early and the late stage, because this is one of the lower grade type of lymphomas. Mantle cell lymphoma, just like diffuse large B-cell lymphoma, is one of the high-grade lymphomas. And these are mostly diagnosed late stage at the date first seen in your clinic because ang bilis niya. It's very aggressive. It's a fast. Symptoms appear late, no? And you don't get to the clinic until you have these kinds of symptoms. Since it is one of the high-grade types of lymphomas, almost all are treated with chemo and radiation. Okay, so disease-specific survival, 5 to 10 years, 5 and 10 years, 62, and then 32. So it's not as low as the diffuse large B-cell lymphoma, but not up there like the MALT and the follicular lymphoma. Okay, so just a summary, those is different subtypes of lymphomas. So most common is the EMZL, then diffuse large B-cell, follicular, and then mantle cell. Low-grade lymphomas, better prognosis, yung MALT and yung follicular. High-grade lymphomas, worse prognosis, the diffuse large B-cell and the mantle cell. So just a few more slides. 5-year lymphoma-related mortality in ascending order, as it is confirmed that yung MALT and yung follicular, yung mga low grade, konti lang mortality at 5. And then yung diffuse large B-cell and other more aggressive have higher mortality. And just to show you again, 5-year disease-specific survival, MALT and follicular high, and then biglang drop sa mantle cell and diffuse large B-cell. So this is just a slide I took from my lecture in last year's annual meeting. When dealing with these tumors, kailangan complete yung PE natin, complete yung history natin. Proptosis, it's a very non-specific symptom. That's why yun nga yung title ng lecture natin. You never know what you'll get. That's why it's important to do a complete history, PE, and a biopsy in these types of patients. Thank you.